My name is Elina Suzuki, and I'm an analyst and advisor at the OECD. And I wanted to talk to you today about some of the work that we've been doing on dementia for the last couple of years. I'm wondering if I can get my slides. There we go. Thank you. So I wanted to start with a couple of slides of introduction because I think the OECD isn't necessarily the most usual suspect at an Alzheimer's conference. So what is the OECD? We're an intergovernmental organization focused primarily on economic analysis and advice. And I think maybe the easiest way to think about us is as a sort of economic think tank. Our members are states and traditionally the most economically developed countries in the world, although we've been expanding in recent years, and our most recent members are Lithuania, Latvia, and soon to be Colombia. And so as the organization has kind of developed and our members have expanded, we've also shifted our focus from just economic development to looking more at social policies, including health. And when it comes to health, like the rest of the organization, our focus is primarily on developing and collecting internationally comparable health data and applying this analysis to health policies. And our member states include countries with some of the oldest populations in the world, including Japan, where I'm from, Italy, Germany, for example. And so this means that as the populations are set to become even older in the coming decades, and the proportion of people, especially 80 and above, is growing and will more than double by 2050, many of the OECD countries are grappling with a lot of the both opportunities but also challenges that accompany population aging. And this includes dementia. Especially given that the population above the age of 80, above the age of 85 is growing so quickly in OECD countries. Many of the countries that we work with are very interested in looking at this issue to prepare and better be able to respond to this growing challenge. So delivering better quality care and also promoting prevention and risk reduction that could bring the number of people developing dementia down could really help to improve both well-being and result in significant cost savings to health and social care systems. Similarly, reducing the prevalence of dementia, but also expanding and improving the quality of care and the quality of services that are available for family carers could really help informal carers and family carers as well avoid poor health themselves. So in the last couple of years at the OECD, we undertook a project to better understand what our member countries are doing in terms of dementia care, both for people living with dementia as well as their family carers. And we undertook what you can consider to be sort of a two-pronged approach to this work. Firstly, we wanted to understand what policies countries have in place with regards to dementia care across the pathway of dementia from diagnosis, risk reduction, all the way to the end of life. And then secondly, and Kate's question in the last session kind of relates to this, we wanted to know how well these policies are actually working. So who's actually measuring what? What data do we actually have related to understanding whether or not these policies are working and the impact that they have on people with dementia and their families? Because today what we found is that there's incredibly little data. And there are very few indicators that actually say what the impact of even really well-intentioned and probably very effective or positive policies are. And similarly, in the health system, we've really been focused on looking at clinical outcomes for a very long time. And this isn't necessarily always the most relevant when it comes to effective policies that will really improve quality of life for people with dementia and their carers. So I want to start with identifying dementia, which is an issue that Bernd also brought up in his presentation. And what we found is really across the board, countries really need to make significant improvements to better identify dementia. Even as countries are recognizing the impact that it has in their countries, there's so much that we still don't know. We estimate that the majority of people in OECD countries who are living with dementia have not received a diagnosis. And one interesting thing that we found is that to improve access to a timely diagnosis, which is a policy priority in many OECD countries, many countries have been emphasizing the role of primary care and primary care doctors on detecting and then also diagnosing and caring for people with dementia. So in at least 26 OECD countries, for example, primary care serves as the first point of contact, and formal diagnosis is possible in primary care in at least 9 countries. But again, we run in here to a number of problems, really. Physicians average just about 12 hours of dementia training in medical school, and while continuing medical education for dementia is available, it's not mandatory, which means as a consequence, many physicians may lack the kind of training to diagnose well. Similarly, many systems are set up in a way that would be disadvantageous to encouraging a very effective detection and diagnosis in terms of promoting a longer clinical visit, for example, rather than pressuring people to really see as many patients as possible. Something else we found that was interesting is that a number of countries have expressed interest in promoting cognitive screening. So while this isn't a full dementia detection, incorporating more cognitive screening tools, basic cognitive screening tools in general practice visits is something that is still rare, but is definitely on the upswing. I want to turn now to this issue of community care, which we also found is incredibly fragmented. For people with dementia who wish to live at home, if they're given the proper supports from health and social services and from community services, they should be able to for a long time after they've been diagnosed. But what we found is that in the majority of cases, people don't receive appropriate information and support following a diagnosis. Care pathways for people with dementia, for example, remain the exception rather than the rule, and they rarely include the needs of the families in addition to the needs of people living with dementia. In one bright spot, over 90% of OECD countries reported that they had at least some dementia-friendly community initiatives in their countries. And I won't go into too much detail because I think these examples of these have been really comprehensively covered by some of my panelists. But one aspect that I wanted to raise here, or two aspects, is one, governments can really play an important role in bringing attention to dementia-friendly activities. But two, these activities are overwhelmingly really built from the ground up, from national organizations, from community organizations, from really active advocates, volunteers. And this, I think, is incredibly positive and can really make sure that these services are tailored to the needs of a local community. But at the same time, it means that whether or not people today living with dementia in too many communities have access to dementia-friendly services is kind of the luck of the draw about whether or not they have an active advocacy organization, whether they have some really active volunteers and advocates living near them, or whether they don't. And what we also found is that there's very weak support for family carers. So while informal carers provide the majority of dementia care around the world, we know that, and the costs of informal care represent a high proportion of the total costs of dementia care, we found that carer support interventions, where they do exist, are rarely targeted at people living with caring for people with dementia specifically. So carer support interventions tend to be developed more broadly and don't necessarily focus on the needs of those caring for people with dementia who often have separate or even more intensive caring needs. Similarly to the issue of dementia-friendly communities, the availability of training services, of respite care, of other programs remains quite weak and is very much dependent on community capacity in many countries. I also wanted to talk a little bit about the needs of and the services available to the formal long-term care workforce. While dementia-specific training for formal care staff is available, we found that incentives to actually encourage care workers to improve their dementia skills remain the exception rather than the rule. Just 4 countries, for example, have developed financial incentives targeted at care facilities or at local authorities to incentivize dementia training. And frameworks to develop, frameworks to recognize what the core competencies are needed to actually care effectively for dementia are incredibly rare, even though they can help to better monitor the skill level of care workers and identify the gaps and where further training is needed. We also found that there's very inconsistent access to suitable, appropriate care facilities. We've seen in recent years a number of innovative residential kind of care facilities emerge and growing recognition that normal, traditional care facilities may not be most appropriate for many people living with dementia. And despite the fact that estimates suggest that as many as 70% of people living in care facilities have some form of cognitive impairment, we found that only 4 countries have developed design guidelines and advice around making care facilities suitable for people with dementia. And these innovative residential communities really remain the exception rather than the norm across the board, and are often private, which means they can be incredibly costly to patients and their families to access. I mentioned briefly that as part of this work, we also looked at the availability of data to evaluate the quality of dementia care. And one of the things that we also tried to do is develop new indicators for quality of care, and I wanted to highlight just one of them here. This is an example related to antipsychotic prescribing. And we chose this indicator because this is an area where there's relatively widespread clinical consensus that in most cases, antipsychotics should not be used to treat difficult behaviors in dementia. And yet what we found is that across OECD countries, antipsychotic prescribing rates vary by a factor of more than 2, and can reach, in the highest countries, nearly 1 in 10 people above the age of 65. And this ties back as well to this issue of data. This is for the entire population over 65, but based on some analysis that we did, it looks like almost all of these prescriptions are going to people with dementia. And so you see from this that antipsychotic prescribing is not only high, but the variation also tells us something. It tells us something about the quality of care that people are receiving, even in the case where we know what we should be doing and what we shouldn't be doing. The practice is still really widespread. And I'll also point to the best performer, Sweden. And it's not a surprise that Sweden is the best performer. It's the only country that's developed a registry specifically for behavioral and psychological symptoms of dementia, which allows their care facilities to more actively monitor their quality of care, which includes antipsychotics prescribing. So going back to this issue of data, and it's quite funny because I think data is very abstract and it sometimes feels so removed from the lived experience. But I want to bring it back to this because I think at the same time it's incredibly important, because if we don't know the population that we're talking about, we don't have basic information, it's very difficult to improve many policies. So I mentioned at the beginning that we estimate that less than half of people in OECD countries are diagnosed. But in fact, less than 40% of the countries we spoke to said that they could even estimate their national diagnosis rate. Similarly, we see that many areas of the health system are not effectively linked together despite huge improvements in technology in recent years. And this is particularly applicable to certain areas of the health system that people with dementia and their families use a lot, including primary care. Fewer than 1 in 5 countries, for example, regularly link primary care data. Some countries have developed dementia registries and other new sources of linking data to help fill some of these gaps. This is something that we've seen in at least 6 countries, and a number of others are interested in looking and exploring this. And for some of these countries, this has been a way to be able to really focus on the population and the needs of people living with dementia, and in some cases also complement clinical data about people living with dementia with some more social factors, for example, whether they live alone, what their community support is like, that helps physicians and other carers to give more well-rounded assessment and response to the needs of the individual. So I'll wrap up there, but thank you very much for listening. A link to our report is available, and I'm happy to take any questions.